paper on correlating the intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Tubercular granulomas are the most well-recognized phenotype of intraocular tuberculosis, and these are hypoxic granulomas associated with increased levels of VEGF. VEGF is a known biomarker for active TB disease both in pulmonary and at extrapulmonary sites. The purpose of this study was to evaluate the intraocular VEGF levels in TB choroidal granulomas and correlate them with the clinical regression. The secondary objective being to evaluate the visual improvement in these cases. Ethical clearance and an informed consent was taken, and 10 consecutive patients with intraocular TB granulomas were enrolled. The aqueous sample was subjected to a sandwich ELISA test, and VEGF-A levels were measured using human VEGF antibody pair kit test. Intravitreal injections of bevacizumab and moxifloxacin were given every week till the granuloma regressed, and systemic therapy in the form of 4-drug ATT and corticosteroids were continued. A correlation was then done between the decreasing VEGF levels and the clinical regression of these granulomas. 10 eyes of 10 patients were included, and the mean age of presentation was 25. 8 patients had choroidal granuloma and 2 patients had optic nerve granulomas. This just shows the decreasing levels of VEGF on giving subsequent intravitreal injections, and this table shows the clinical regression of the TB granulomas in these 10 patients who were enrolled in the study. The results which were got in this study, the mean baseline VEGF-A level was found as high as 1000 to 1500 picograms per ml, while the mean VEGF-A level at the time of last injection was as low as 27 to 50 picograms per ml. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting intravitreal injections, and the average number of injections required by these patients were around 3. At baseline, 9 patients had a best corrected visual acuity of less than 636, and this had improved to 4 patients having a vision of 6.6 at the last follow-up, 2 patients with a vision of 6.18, and 4 patients with a vision less than 6 by 24. This is one of the representative cases, a 24-year-old female with diminution of vision in the left eye for last 5 days, already on ATT for pulmonary tuberculosis. You see a large choroidal granuloma in the supranasal quadrant, along with involvement of the optic nerve head and cystoid macular edema at the macula. The VEGF level at the baseline was 927, which had decreased to 422 after 1 injection. You see a beautiful regression of the entire choroidal granuloma. But the patient developed a paradoxical reaction, and this was treated with IVMP and stepping up of the oral steroids. There was a complete regression of the entire granuloma after 2 injections, and the patient had recovered a vision of 6.6 N6. This is another patient with a massive granuloma involving the macular area with a vision as low as 3 by 60, which had improved after 3 injections to 6.18, and you see that the granuloma has totally regressed within a time frame of about 4 weeks. So TB granulomas are hypoxic granulomas with increased VEGF-A levels, and they are said to have VEGF levels as high as 4 to 5 times higher than what is found in AMD CNVM patients. The half-life of intravitreal injection being 2 to 7 days. In non-vitrectomized eyes, it is tending to reduce in these patients because of the breakage of the blood-retinal barrier, secondary to inflammation. This is a typical TB granuloma with caseation necrosis in the center. You have surrounding macrophages, which are having the TB bacilli within them and the abnormal vascularization. These granulomas, the VEGF levels are high, leading to abnormal vasculature around the granulomas, leading to unequal distribution of the ATT drugs, thereby reducing it to a monotherapy and thereby increasing the risk of multi-drug resistant TB. These hypoxic granulomas and the hypoxia associated makes the MTB bacilli dormant, and the INH, which is there in the ATT, is the only bactericidal drug, but it does not act on dormant bacilli. Thus, the need for innovative host-directed therapies. When we give an anti-VEGF, there is a decrease of hypoxia. It avoids the bacilli from becoming dormant and increases the effectiveness of INH. It also normalizes the vasculature of the granuloma, thereby increasing the small molecule delivery of ATT and reducing the risk of multi-drug resistant TB. While moxifloxacin being given, it accumulates in the activated macrophages, which harbors the MTB bacilli, with a higher intracellular to extracellular concentration in comparison to other ATT drugs, and thereby helps in elimination of the MTB bacilli from the macrophages. The VEGF-A levels were measured for the first time in this study, which probably can be used as a biomarker in future. An effort is to normalize the vasculature of these TB granuloma as quickly as possible so that the ATD drugs effectively reach the granuloma and regress them. It was a proof of concept study and hence the small numbers, and it was also a non-randomized study. So these were the shortfalls of this particular study. I conclude by saying that very high levels of VEGF are found in patients with tubercular granulomas, and a monthly injection of anti-VEGF may not be enough to aggressively treat these vision-threatening TB granulomas. A weekly intravitreal injection of anti-VEGF with moxifloxacin given as an adjunct to the ongoing ATT and steroids may help in faster regression of these granulomas. I just acknowledge the contribution of NIN and Professor Ramod Gupta for all our knowledge on ocular tuberculosis. Thank you so much.
Thank you. Manisha, just one question. How you collected this sample for a VEGF level?
So, sir, when we were giving the intravitreal injection to these patients, we just did an AC tap, which we normally also do sometimes because of the high IOP, because we were combining two drugs. So at the end of the procedure, we just collected a small AC tap sample. Thank you.